Hey, welcome to my podcast. My name is Dr. Brendan McCarthy. I am the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. Thank you for tuning in. Today, we're going to get into endometriosis. I'm going to discuss different ways we run labs around it and then how we treat based upon those labs. Before I do, please just scroll down there. You'll see there's a subscribe button. Subscribe. If you like it, just press like. If you want to share it with someone, share it. This material I think is important. It's rooted in experience. I'm not here to sell you a product. I never will. You know, I will recommend a supplement, which I'm going to today, to talk about different supplements. I think they're effective, but I'm going to be really purposeful and tell you the certain brands that I do use in clinic and some that I may be not using. But I want you to know it's not because that company pays me. No company pays me to be here. None. And I'm also not here to solicit you to come to my practice either. I want you to know this to me is it's like a labor of love. And we do this, and your trust means so much to me. And I think that would violate our trust if you thought I was trying to promote a product or a brand or anything. I'm not. I just want you to get the things that work, and where my satisfaction, where my payday at the end of the day, it comes from seeing the positive impact something has on a person's life. If you're involved in healthcare at this level where I am, this type of healthcare, not all types of healthcare have this. A lot of healthcare is not good. Most healthcare is not good. But when you're in this area, my arena, it is what drives us. I'm here for the feels. I am. I'm here for the feels. That's why I'm here. And the degree that I need to build a business around me, I'll do that. But that business better not get in the way of me having the feels. And those feels are when I see what we did worked and I see a change in someone's life. It's such a big part of what we do. Anyway, back to the product. Back to the product. Freudian slip. It's not back to the product because there's no product. It's no product here. We're going after caring for you. So when we last left off with endometriosis, we were talking about, the causes of it, the things that occur in the background and areas that I think should be focused on a little bit more. By no means is this exhaustive. This is not a masterclass in endometriosis. This is me drilling down on one specific area of endometriosis that I feel is important to look at and treat. Maybe more than one, a few areas I think that are overlooked and missed. I'm just going to drill into those. Today, I'm going to talk about the lab work around it and what you do with the lab work and how you treat. So, if you look at endometriosis, and I got a quote because I thought this is funny, not good funny, like haha, but sad. This literally comes out of the book. Measurement of biomarkers in endometrial tissue, blood, menstrual, or uterine fluids has no role in diagnosis of endometriosis. Do you see that? That's like us trying to understand you has no role in this. That is absolute idiocy. Now, if any doctor is looking at this and wants to argue it, don't. Because there's mountains of research that discuss the role endometrial hyperplasia, where that comes from, how that it leads to endometriosis, and how the monoamine pathway plays a role and the role of melatonin. It also discusses how, anovulatory cycles are important. These are all things, and inflammation, these are all things we can test. This is not only we can test, we must test if we're going to treat this woman. So if we're going to treat this woman with respect and regard, we're going to look at every aspect we can to understand them. And that means lab work every damn time. And it's worth it. You're worth it. So lab work. What labs do we do? Base stuff we do. Of course, you always do your base panel, nutrition. We do a CBC, CMP. Those are important things always. There's other components to that, and I've done episodes on that before. I'm not going to drill down into that. But the key things here, I'm going to talk a lot about that estradiol and progesterone testing. You want to run the lab work for the estradiol and progesterone. You want to see where they are day 21 of the cycle. So you want to run a day 21 panel. You want to see where the estradiol is. You want to see where the progesterone is. If you're not ovulating, progesterone is going to be low, and so you want to make sure you bring that progesterone up. You want to understand that. So no matter what, you're running a day 21 panel of a cycle. If they're not day 21, you want to be somewhere in the luteal phase, second half of the cycle. You want to try and figure that out. If they're not cycling at all, there's ways to approaching that. That's a different episode, but let's stick with just this one today. So if their progesterone comes back low, we're going to start treating that. But that's still not enough. Why aren't they ovulating? Why didn't they ovulate? What components could be at play? Prolactin. Prolactin, even in the normal range, if it's on the higher end of the normal range, you're not going to ovulate very well. It won't be, it'll cause luteal phase insufficiency, it is, where you still have some progesterone. You did maybe ovulate, but it's not a lot of progesterone. You want to understand that. You want to see that. You want to run cortisol panel on this person. That's going to be in the morning. You want to do that when they first wake up. You want to get an AM cortisol, and you see where their cortisol is. Cortisol is a good way of getting an understanding of stress, just on the fly, quick draw. There's more information we need from them to truly understand stress. We can at least get the first imprint of what's going on with them by doing a morning cortisol. Morning cortisol in a woman should be, in my opinion for health, 14 to 18. I like 16, 17. Those are good numbers because that's the circadian rhythm. You want that cortisol high in the morning, it drops off in the afternoon, and in the evening you go to sleep. If it's below that, you want to start thinking about stress in their lives, chronic stress. If it gets really low, below 10, you definitely have some significant stress going on in the patient, and that will affect ovulation. So that's another one we want to run a lab. What are the things we can look at that are helpful for these women? Thyroid. There's a strong association with autoimmune thyroiditis and endometriosis. So we want to run a full thyroid panel. We know that when TSH is too elevated, that plays a role in this. So we run a full thyroid panel on our patients, including the autoimmune panel. There's certain nutrients we know that help prevent endometriosis and play a role in endometriosis. And then there's some that we suspect will be helpful. Magnesium is one of the ones we suspect is helpful. And why is that? Well, we know women with endometriosis statistically have lower levels of magnesium in their bodies. Well, why would that be a player? When you have estrogen dominance, estrogen is too high, your body uses magnesium as part of the detox pathway to metabolize estrogen out of your body. So if you have a lot of estrogen, you're going to be burning through magnesium. Magnesium does many things in the body, but one of the big things it does, estrogen metabolism being one of them, one of the other things it does is a smooth muscle relaxant. We know in endometriosis, the fallopian tubes contract irregularly and it's more spasmodic. And that could be playing a big role. They still suspected the role that it plays, but that contracting irregularly could be what leads that endometrial tissue to leave the line of the uterus, leave that tissue area and move its way, migrate itself back out into the peritoneum. That is entirely possible. That's how that's occurring. So magnesium has been advocated for in the treatment of and prevention of endometriosis. I don't like to give magnesium just blankly. Here's your magnesium. Thank you for shopping. And I know you could buy it over the counter. I know it's there, but we want to know what you need and whether that is an issue. So running a magnesium panel, and I run red blood cell magnesium because magnesium tends to live inside the cell. So you want to do what's called a red blood cell magnesium. We're measuring how much magnesium is inside the cell. That's more accurate. That's a good way of looking at this as well. If it's low, we want to treat that. We want to help them with giving that magnesium. And almost always it's low in my experience. But still, don't assume. Run your lab. Other things we look for, a little out there, is going to be when we're looking at antioxidants. And I'm saying this because so many women have oxidative stress. You have so much oxidative stress. There's so much inflammation. When you have an inflammatory diet, let's say, when you look up endometriosis and the way they're telling you to treat it, your regular doctor, you look up on the book, even my books will say this, tell them to stop eating red meat and fried foods. It's so awful. That's so awful. It makes the red meat industry look like it's evil. Let me tell you the truth. I know many of you are vegetarian and many of you are vegan and many of you have different variances in there. And I want you to know, I respect you 100%. Your choice to what to eat is your choice. My role is to make sure you're healthy and make sure you're doing a good balance of things. So is red meat really bad for endometriosis? No. Red meat is actually not the culprit. It's not the bad. Where you're having a problem, why it's associated with red meat is this. When you eat red meat that was raised on corn, that's going to have a higher amount of arachidonic acid in there, and that is more pro-inflammatory. So when your body has a normal inflammatory response to something, it's going to be more of a hyper-inflamed response because arachidonic acid is more pro-inflammatory. Now, if you were to have red meat that was grass-fed and grass-finished, that actually does not have arachidonic acid in there like that. That's actually less inflammatory. So you have a big difference between the two ways that meat was raised and how the impact it has with inflammation. So it's not, the problem is not the red meat. The problem is the way the cow is being fed and how that's going to impact your inflammatory pathways. That is the truth. Now, some people would say, well, red meat's evil because of all these reasons, and you have your reasons, but I want to make sure when we tell people not to eat red meat, we're using honest reasons, not kind of like grouped reasons, like red meat is bad in and of itself. It's not. It's for this. We have all the other things we can discuss, ethics and environment, whatever you want to do, we can have that conversation. But when it comes to this, we must be clear. It has to do with arachidonic acid and linolenic acid, the different types of fatty acids you're getting sourced from your food. So anytime you're eating inflammatory food, anything you have in your body that's pro-inflammatory, processed foods, trans fats, fried foods, these things, these types of oils tend to be more inflammatory, not like fish oil. You know what I mean? Not like, grass-fed, that there's a difference. And it's important to see those women and move them more towards that diet. But also we want to help lower the inflammation. So we need to think about what antioxidants can we help with? What ways can we help promote their body be less inflammatory? So when we run an antioxidant profile on them, that's one of the tools I want to use. And another lab we can do that's available through LabCorp, I don't work for LabCorp, it's an omega check where I can see how much omega-3 fatty acids you have. What's the ratio of inflammatory versus non-inflammatory fatty acids in your body? I can test that. And those women who have endometriosis, we tend to see them being more inflammatory. So we want to push it in that direction. We want to give them the right amount of like fish oil and adjust their diet so I can run the lab down the road and verify there was a benefit to these people. When I say to you the melatonin impacts the migration of your endometrial lining and how that moves out into the tissue around you, and that by normalizing melatonin has a positive effect, we got to test that melatonin, don't we? So you can do that lab. Now, I know Quest does that test, SnoreQuest on the States. I don't think LabCorp does. Every time I look, they don't have it on their offerings. But Quest does do that lab for you. There's other boutique labs that'll do it, but I like to stick with the insurance-based labs because if your insurance covers it, we got that. And I do such a high volume of lab work in my office, I'm able to get a better cash price for my patients. So I tend to stick more with the big lab companies that have the better price points. Sometimes I still need to use a boutique lab. I'm very careful because I know sometimes those prices kind of jump up a lot. So just be aware of that. Another thing we test for, let's just understand that pathway completely. I will run your serotonin as well. So a serum serotonin panel and a serum melatonin panel will be helpful. Now the melatonin panel, we should either be running it late at night or in the morning. The morning will be very low anyway. So night's better. That's how we're going to navigate running a lab on a person in the evening. We have to talk about that. We have to schedule it. We have to get our staff on site when we're doing it. But that can be done. That can be done. And a lot of times it is essential for this. The final one I'm going to say, this is a little controversial even for me, is running the endocrine disrupting compound panel. There's a lab you could do through Quest where I'm testing BPAs and phthalates in your bloodstream. And why is that controversial? It's because these compounds are in and out of your body real fast. They don't last. So when you're onboarding, you're eating foods that are exposed to this stuff, it just, that lab tells you what you just had in the past few hours, past 24 hours. It doesn't let me know the trend. So if you ate really well in the past 24 hours, it's not going to be on that lab. So it's useful to have that lab available, but you always have to know when you run it, what you should be expecting and what it's going to be looking for. Okay. Like the melatonin a minute ago, I said, if I run the melatonin in the morning, it's going to be low, and that's not going to really infer much for me how much they get at night. Right. So it's important to know what your lab's doing, when your lab should be run, and the overall effectiveness of the information you're getting from the lab. When it comes to treatment, if you think about all the labs I just said, it's basically treating around the labs. If the patient presents to clinic and she has low progesterone, we're going to make sure we give her progesterone during the second half of her cycle. 200 milligrams of sublingually dissolving troche is my favorite way over the years, has been most effective. But I'm open to any way that works. Topical does not work for this in my experience. That doesn't mean I'm not going to try. I'll do what I can with what I have with my patients. But my preference is the oral troche, and we'll do that at 200 milligrams, as I mentioned, and we run the labs to verify. What else? When we have the patient who's coming in with thyroid, we're going to make sure we monitor thyroid. If they have autoimmune thyroid, we want to treat that. Sometimes it's diet that solves that. Sometimes we use low-dose naltrexone. That'll do that. There's different ways I can modulate autoimmunity, and I would do that to the best of my ability in those cases. We're looking at magnesium. If their magnesium levels are low on the red blood cell magnesium panel, We're going to give them magnesium. I prefer magnesium citrate. There's always magnesium malate. There's other versions of it that could be more targeted, but specifically like MagCit, easiest for me. Antioxidants. When I said that earlier, antioxidants I run for, coenzyme Q10, that's a easily run panel, and I treat that to bring up to the optimal level. Vitamin C, we can test ascorbic acid in our patients, make sure they have adequate levels. Glutathione, which is what everything ends up becoming in your body. Glutathione is the most powerful antioxidant your body makes. We can supplement that with an injection, but a lot of times I know if I build up the other pathways of antioxidants in their diet and their lifestyle, it'll build up glutathione in and of itself, so they don't always need an IV of glutathione. They can just do these other protocols, and I can see that bring up the glutathione naturally, so I do monitor that. We do the omega-3 testing to see what their omega levels are, and then I treat and I prescribe. Omega-3 fatty acids are tricky because patients a lot of times don't want to eat fish. I get it. Not everyone likes fish. But if you're going to do like a fish oil, like Nordic Naturals, and I don't work for them, but I love that brand because they're just really higher quality. They're good quality, over the counter. You can find all over the place. The thing is, though, they'll swallow the pill and they feel like they're burping up fish oil for the next several hours. The reason why that happens is that you have this little gel cap with the fish oil in it. When you swallow it, it gets into your stomach, it starts to dissolve and break down, and then pretty much that capsule will break open, the gel cap breaks open, and the oil floats to the surface, and there you have your oil right at the surface of your stomach at the very top, and that's why that happens. How you can get around it? Freeze it. Freeze those omega-3 supplements, and you take it as a frozen pill. That's going to slow down the breakdown of the pill, the gel cap you did. Furthermore, eat food right after it. So take the pill, then eat some food, and that's going to put it down so the oil will not be able to go right to the surface of the fluids in your stomach. It's going to kind of be held down there by the food. This is, over the years, has been what's worked for me with fish oil. And then finally, prescribing around these women, if their melatonin is low, that's the biggest one we talked about. Studies show 5 to 10 milligrams of melatonin at night is what works. It's what works. Problem with melatonin is I can test it, but I'm giving you such high doses, it's going to look super physiological on the labs. Further, when I'm giving it to you at that high level, even though I change serum levels, I don't know what it's doing in the lining of the uterus. I don't know what it's doing for the migration. I'm just using the research that it helps. So a lot of that's going to have to be based upon, the results are based upon symptom resolution using that. That's been my go-to. And then serotonin, if a person has that monoamine pathway really slowed down, I know giving them progesterone is going to help that pathway turn back on. But we can give them pregnenolone as an over-the-counter. That helps. Maybe 30 to 50 milligrams at night before bed. That can also help with that pathway, making serotonin and melatonin. Another thing we do is 5-hydroxytryptophan, which is a direct precursor to serotonin. That I can give a patient as well. And that can be helpful, 1 to 300 milligrams. That's been my go-to. And again, I really would like to always do lab work to follow up that I did the right thing, that it moved the labs in the right direction. But with endometriosis, so tricky to show that I caused everything to get better. A lot of times we're stuck with just, symptom resolution and lab improvement, and then see how they're doing from there. I hope this series helped. I really do. I know I will never understand the pain of endometriosis. I will never experience it. I've witnessed it. I've been around it, and this happened to people I dearly love and care about. Experiencing this, throughout my life as a young man all the way through, and this is dedicated to those women that I've known throughout my life that have suffered through this, in the hopes that I can help you not go through that same level of pain, and that you also would feel seen by a physician and cared about. So to the degree that helps, I'm thankful for being able to do that. Please like, share, and subscribe. Tell your friends. Spread it around. Let me know if it's good. We will make more content based upon your comments. We always do. Justin and I read all your comments, and it really helps us drive the content of the podcast. And that's what we're here for. So thank you very much, and I'll see you at the next episode.